السلام عليكم كل عام وانتم بخير. Today I'm going to discuss results of many studies in which we looked at biomarkers of inflammation in the aqueous humor of patients with specific endogenous uveitic entities. These are the papers that are published over the last 15 years. I'm going to give a summary of these papers. But before I start, I would like to thank my friends and colleagues. Without them, it would not be possible to perform all this work over the last 15 years. From the right, Professor Jo van Damme. Jo van Damme is the director of a research laboratory at Reagan Institute of Medical Research. And this laboratory is only focusing on cytokines and chemokines. And he by himself, he described for the first time several cytokines and chemokines. The most important was IL-1 beta, interleukin 6, and interleukin 8. Once I asked him, how do you discover them? He said, we smell them. And next is Professor Sophie Straub. She is his student, and she is currently the director of the same lab. Then Professor Kali Gabbous, immunologist, and Professor Obdanakar, he is also an immunologist, and he gave several grand rounds here. And this is during one of our meetings. So as you know, endogenous uveitis is a heterogeneous group of diseases, and they're frequently associated with systemic autoimmune and autoinflammatory conditions such as sarcoidosis, Behçet disease, HLB27, and Vogt-Negg-Harada disease. As a uveitis specialist, I used to ask myself when I examine a patient on the slit lamp, what is the cause behind this recruitment of so many inflammatory cells in the aqueous humor and vitreous? And if you look at patients with uveitis, the clinical findings are completely different. So patients with HLB27 uveitis clinically are different from VKH, different from Behçet, different from sarcoidosis, and so on, which means that these differences in clinical phenotypes indicate that definitely there is a difference in the immunopathogenesis of these conditions. This might not be of great importance in the era of using systemic corticosteroids that will suppress everything. But this is now very important in the era of biologics. Because with biologics, we target a specific molecule. Before we use a biologic for a certain uveitic entity, we have to know if this molecule, such as TNF-alpha or interleukin 6, is present in this patient. And this is, for example, I'm going to show you examples like this is the clinical phenotype of HLB27-associated uveitis with a fibrous reaction in the anterior chamber. It's different from Behçet. Behçet was hypopion with severe vitritis, retinitis, and typical fluorescein angiographic feature of leakage, diffuse leakage involving the optic nerve, involving the large vessels and the small capillaries. This is very characteristic for Behçet. Another patient with Behçet with the typical fluorescein angiographic leakage from the capillaries. This you see it mainly in patients with Behçet disease. Then Vogt-Negg-Harada disease with exudative retinal detachment. This is a very early case that presented what we call it therapeutic window of opportunity, and typical fluorescein angiography and ICG, which is full of hypofluorescent spots corresponding to inflammatory foci or granulomas. So this is a classic case of VKH, which is a granulomatous inflammation involving the choroid. The other two examples were non-granulous inflammation, and VKH with matum fat KPs, sunset golofundus, chronic recurrent VKH, iris nodules, as you can see here. So VKH, and then sarcoidosis. It's granulomatous disease because you can see large matum fat KPs. So these are different clinical phenotypes of uveitis. We know that cytokines and chemokines control inflammation and have important roles in the pathology of various endogenous uveitis entities. Thus, they can represent targets for treatment. For example, tumor necrosis factor alpha is a major pro-inflammatory cytokine, and we have biologics that target tumor necrosis factor alpha. The most famous are infliximab and adalimumab. And this treatment is very effective in patients. And as I shall mention later, patients with patient uveitis, they have high levels of tumor necrosis factor alpha in the eye, in the intraocular microenvironment of this kind of inflammation. Anti-interleukin 6, we have biologics that target interleukin 6 receptor. So anti-interleukin 6 pathway are available. And before we use them, we have to know which uveitic entities are driven by interleukin 6. Therefore, it is of major importance. That's why that was my dream 20 years ago, that I need to specify, to prepare a map for cytokines, chemokines that drive each of these uveitic entities, to characterize the chemokines, and this will allow us first to understand the immunopathogenesis of each disease, allow us to specifically target each disease by the proper biologics. We know that biologics that target B cells are not effective in, for example, in Behçet disease. I shall give you an example. A patient that Dr. Belushi and I saw and managed. Young female patient admitted to neurology because they thought that the patient had neuroBehçet. They have multiple sclerosis. So they give the patient B-cell depleting biologics, rituximab. The patient became worse. The patient came to King Abdulaziz University Hospital. I saw the patient. We discussed the case together. I told Abdurrahman, this is Behçet. And as you know, neuroBehçet can give findings in the brain similar to that of MS. We communicated with the neurologist, told them your patient does not have MS, this is neuroBehçet. And we started the patient infliximab. Second day, she improved. This is a good example that you cannot use one biologic to treat all autoimmune diseases. You have to use the proper biologic for this particular disease. So we looked at cytokines. All cytokines that can be looked at using a multiplex assay. We use 2 multiplex assays. Each one can detect 60 molecules. So I'll start by those that give negative results. Interleukin 1 beta, interleukin 4, interleukin 12, interleukin 21, 22, 23 were not detected. What does this mean? It means that these cytokines cannot be used as a target for treatment. Is that correct? Then, that was very interesting. 10 years ago, an American company called Zuma. I found a phone call from them. They told me that we are developing a new biologic that target interleukin 1 beta. And a French company called Servier will produce it, to sell it. We want you to be involved in a multi-center study to investigate the efficacy of gefacizumab, which is a monoclonal antibody that target interleukin 1 beta. I had a meeting with them in Paris, and I told them, based on our data, interleukin 1 beta is not present in the aqueous humor of patients with Behçet disease. So theoretically, it would not be effective. I discussed this with Professor Jo van Damme, and we decided not to be involved in this study. And then what happened? 6 months later of starting the study, Zuma said today the monoclonal antibody gefacizumab developed in collaboration with Servier has failed the study. So meaning that interleukin-1 beta, this molecule could be effective in other diseases driven by interleukin-1 beta, but not in Behçet. So this is the importance of knowing what's going on. Now, we'll start with tumor cause factor alpha. This is a pro-inflammatory cytokine, plays central role in both the induction and the maintenance of inflammation and in autoimmune reactions. Our data showed that if we look at all patients versus controls, our control was in fact aqueous humor that Dr. Abidan helped me to get this aqueous samples at the time of cataract surgery. So we use this as a control samples. And this is patients with uveitis. When we lumped all the patients together, tumor cause factor alpha was significantly upregulated in patients with uveitis. But then when we separated the patients, Behçet, then you will see that Behçet has highest level of TNF alpha. And that is why infliximab, which is an antibody against tumor cause factor alpha, is highly effective. We never use anti-TNF alpha agents in patients with VKH because they don't have high levels of tumor cause factor alpha. We mainly use it in patients with Behçet. Now, this is an example of a patient with blinding Behçet disease. Now, currently, we are using infliximab as a primary treatment for all patients with Behçet uveitis involving the posterior segment. So this is a patient who presented with a blinding disease, with vitritis, with retinitis, and typical fluorescein angiography, and this is after infliximab treatment. I'm following this patient for at least 10 years with 20/20 vision. Another patient, and after infliximab. So we learned it for the first lesson that tumor cause factor alpha is highly expressed in patients with Behçet disease. That's why these patients respond to anti-TNF alpha agents such as infliximab. Interleukin-6. Now, currently, we have biologics that target interleukin-6 pathway, not only systemically, but also we have intraocular injection, anti-interleukin-6 for intraocular injection for uveitic macular edema, and there's a trial for also diabetic macular edema. So interleukin-6, it is a multipotent cytokine. This is, by the way, the one who was described for the first time by Professor Jo van Damme. So it is a multipotent cytokine regulating both B and T cell activation differentiation. It plays a pathological role in inflammatory and autoimmune diseases. Now, all patients, significant high levels, but the levels of interleukin-6 usually very high, nanogram per ml, and TNF alpha picogram per ml. And if you look here at the levels, the highest levels were for HLB27, uveitis, followed by Behçet, and very low in VKH. And this is the control. It means that based on this data, tocilizumab, which blocks interleukin-6 receptor, should be most effective in patients with HLB27 and in patients with Behçet disease, and you should not use it in VKH and sarcoidosis. So the interleukin-6 receptor axis might be a target pathway for the treatment of HLB27 associated uveitis and Behçet disease. And there are clinical trials demonstrating the efficacy of tocilizumab, which is a humanized anti-interleukin-6 receptor antibody for patients with rheumatoid arthritis, systemic juvenile idiopathic arthritis. And it has been shown also to be effective in refractory uveitis. But unfortunately, I discussed this in Florence during the Fluoretina meeting and in the uveitis session that if we want to use tocilizumab, we have to make sure that we are using it for the right patient. Because unfortunately, most of these studies, they lump all uveitis patients together and they give them medication like adalimumab, and then they look at the outcome. without distinguishing which disease responded and which disease did not respond. We looked also at interleukin-10 family of cytokines. This included interleukin-10, 19, 20, 22, 26, 28A, and 29. Out of this family, it was only interleukin-19 which was significantly higher in the aqueous humor of patients with uveitis. And it was highest in patients with HLA-B27 uveitis. This data suggests that interleukin-19 might be even biomarker for HLA-B27. This, by looking at here, this is the HLA-B27, huge difference between HLA-B27 uveitis and the other uveitic entities. But also looking here, because in this study we looked also again at TNF-alpha, you see that TNF-alpha levels are highest in Behçet and the HLA-B27, and interleukin-1 beta almost not existing. A major source of IL-19 is monocytes. In monocytes, IL-19, it's a very important function for it. It induces monocytes to produce tumor necrosis factor alpha and interleukin-6. So it even induces the monocytes to produce strong pro-inflammatory cytokines. We looked also at the soluble cytokine receptors, soluble CD30, soluble CD163, and soluble tumor necrosis TNF-alpha receptor 1 and 2. What was interesting? Soluble CD30 were highest in patients with VKH disease, which means that VKH is also driven by CD30 T lymphocytes. The levels of soluble CD163 were upregulated. So what is the source of the soluble CD163? It is a marker of M2 monocyte macrophages. M2 monocyte macrophages are the macrophages that they are in the, if it is present in tumors, they increase angiogenesis because they induce VEGF, and they make the prognosis worse for the patients and increase the risk of metastasis. So it is pro-tumoral monocyte macrophages. And this CD163 indicating that we have in uveitis monocyte macrophages of the M2 phenotypes. And this is to show you that the soluble CD, like this is soluble CD30, it was highest in patients with VKH disease. Now, more importantly, we looked at chemokines. And we have a very famous group of chemokines that act specifically on neutrophils. And as you know, neutrophilic inflammation is important. Neutrophils, they carry two receptors, CXCR1 and CXCR2. And these receptors are acted upon by ligands to chemo-attract and activate them. We looked at this neutrophil chemoattractants, and our findings first showed that the highest level or the highest chemoattractant for neutrophils was the CXCL1, and then blue is Behçet, light blue is HLA-B27, and then VKH and sarcoidosis. Big difference. So this data are very important to tell us or to confirm that the neutrophils are playing a major role in the pathogenesis of Behçet and HLA-B27 uveitis, but not in VKH. So it is mainly involved in acute non-granulomatous uveitis. So these observations are consistent with previous reports showing that neutrophil infiltration and activation are important pathophysiologic features in Behçet and HLA-B27 uveitis. Therefore, there are currently experimental studies to block the receptors, CXCR1 and CXCR2 on neutrophils. If you want to use these blockers in the future, it should be only for Behçet. And this is an experimental drug which is used nowadays. You should use it only for Behçet and HLB27. As you know, also T helper 1 lymphocytes are involved in autoimmune diseases, and the T helper 1 chemoattractants, there are 3 chemoattractants to chemoattract T helper 1 lymphocytes, and all of them are induced by interferon gamma. Do you know that interferon gamma is one of the cytokines which is a marker for T helper 1 lymphocytes? So these 3 chemoattractants, they act on one receptor called CXCR3. We looked at them and we noted that it was only IP10 or CXCL10 which is present at high levels compared to MIG and ITAC. And the levels were significantly higher in patients with acute non-granulomatous uveitis. So if you use to block the receptor, you can use it mainly for Behçet and HLB27. Now coming to lymphoid chemokines. This group of chemokines, they act specifically on B lymphocytes. I'm going to make it very short. We know that B lymphocytes are playing a major role in pathogenesis of autoimmune inflammatory conditions, even those that were supposed to be driven by T lymphocytes, such as rheumatoid arthritis, myasthenia gravis, systemic lupus erythematosus, and multiple sclerosis. So when we looked at this chemokine, CXCL13, or called B-cell chemoattractant 1, this is VKH. It is mostly present in VKH with very low levels in the other types of uveitis, suggesting that CXCL13 is a marker for VKH, and also suggesting that VKH is driven by B cells. If VKH is driven by B cells, so VKH can be treated, or resistant VKH, by biologics that deplete B cells. And the biologics that deplete B cells that we have is called rituximab. It is anti-CD20. So when we looked at the literature, there are several diseases, uveitic entities, that were shown to be driven by B cells, and this included sympathetic ophthalmia. You know, sympathetic ophthalmia is very close to that of VKH. If you look at the choroid in sympathetic ophthalmia, it fulls of B cells. Multifocal choroiditis, progressive subretinal fibrosis, and VKH. So we conducted this study in collaboration with Professor Philip Castellane from Ghent. He gave me eyes inoculated because of sympathetic ophthalmia. And these eyes were inoculated from the type of, do you know Professor Francois? He was the chairman of the Department of Ophthalmology in Ghent, and he was famous because he is the first chairman of the Department of Ophthalmology to have a genetic lab in his department. So these eyes were inoculated from the type of Professor Francois from patients with sympathetic ophthalmia. So this is the routine histology showing the choroid very much thickened with inflammatory infiltrate and giant cells, epithelioid cells. But then when we did staining for T cells and B cells, this is T cells, the red coloration indicating the stained cells, and this is B cells. You can see we have more B lymphocytes compared to T lymphocytes in patients with sympathetic ophthalmia, which is very close to that of VKH. You have this similar histopathology. And this is staining for monocyte macrophages. You can see there are a lot of monocyte macrophages. This is the lymphocyte nodule. It's a histopathologic terminology, and it is full of monocyte macrophages. And this is HLADR, which tell you that cells are immunoactive. So في specific ophthalmia, in our paper, we published, this paper was published in journal I several years ago, that theoretically, sympathetic ophthalmia is driven by B cells. And that's why that was the basis for this paper. This paper that we published, I think last year, and we showed efficacy of B cell depletion therapy with rituximab in refractory chronic recurrent uveitis associated with Vogt-Honeck-Harada disease. For the first time, we used this biologic in patients with chronic recurrent Vogt-Honeck-Harada disease uveitis not responding to conventional treatment. And we showed that for the first time, like this is a patient, young female patient, she became depressed because of the so many courses of immunosuppressive treatment without any response. And you can see the aggressive granulomatous inflammation. And this is after rituximab. For the first time, she became quiet, and we were able to stop systemic corticosteroids. And this has allowed us to do cataract surgery for her by Professor Al-Fawaz. So we could control the inflammation, and we were able, with the help of rituximab, to do cataract surgery without having severe inflammation. And we have several. Unfortunately, I don't understand why all these patients, including this study, were females. It seems that female patients, they have more severe chronic recurrent VKH compared to male patients. So this is a series that we published. And after we published this study, other colleagues started using rituximab for resistant refractory VKH uveitis. So we, with the help of my colleagues in Leuven, we did this table. Endogenous uveitis can be granulomatous, non-granulomatous. Non-granulomatous, such as VKH and sarcoidosis, this is B lymphocyte driven, and because we have B cell chemoattractant CXCL13. The non-granulomatous Behçet and HLB27, this is T helper 1 lymphocyte and neutrophil driven because of the neutrophil chemoattractants and the T helper chemoattractants. Now we looked at CC chemokines, and I'm going to mention this specifically CCL20 because that was a marker for HLB27 uveitis. If you compare it with other uveitic entities, and this is, in this paper, we used to multiplex. So this data results obtained with the bioplex assay, and this data obtained from different companies, multiplex assay, and you see the same pattern, that a patient with HLB27, they have the highest level of CCL20. So CCL20 might serve as a biomarker for HLB27 uveitis. It acts on one receptor, CCR6, and this axis may serve as an excellent drug target for HLB27 associated uveitis. I'm going to skip this. So in conclusion of the first part, our findings suggest that the intraocular levels of cytokines and chemokines differ depending on the cause of uveitis. Do you agree about this now? IL-6 driven responses, immune responses, are more potent in non-granulomatous inflammation, such as Behçet and HLB27 uveitis. If you want to use tocilizumab, you use it only for these diseases. Inflammation mediated by neutrophils and T helper 1 cells appears to be more potent in non-granulomatous uveitis associated with Behçet and HLB27. CCL20 is a biomarker for inflammation in HLB27-associated uveitis. B-cell chemoattractant CXCL13 is a biomarker for uveitis associated with Behçet disease. B lymphocytes may contribute to the inflammatory process in VKH. Our findings suggest that B lymphocytes contribute to the inflammatory process in granulomatous uveitis, particularly VKH disease. Of the members of interleukin family of cytokines, interleukin 19 was highest in patients with HLB27. Soluble CD30 was highest in patients with VKH, indicating that CD30 T lymphocytes are involved in VKH disease. Now, my main conclusion here, and I hope that you will agree with me, that analysis of the aqueous humor from patients with specific uveitic entities can optimize the selection of biologic therapy. We cannot use biologics so blindly, assuming that, for example, adalimumab will function in all your immunopathogenesis of each of these. People, when they talk about uveitis, they talk about as if it is one disease. No, uveitis is different diseases. Just to finish very quickly by discussing this new data that we published this year, in which we looked at an recently new inflammatory biomarker called bintrexin in the aqueous humor from patients with uveitis. In fact, bintrexin was described for the first time by an Italian immunologist from Milano, Professor Mantovani. And that's why it is a relatively new biomarker for inflammation. And this is a paper that's published 2025. I'm going to. So bintrexins are a group of multifunctional proteins, which can be classified as two groups. Short bintrexins, the well-known short bintrexins, as seroactive protein and the serum amyloid B component. Bintrexin 3, the one that we studied, is the prototype of long bintrexin protein. But the short bintrexins, seroactive protein, and the serum amyloid B components are primarily secreted by hepatocytes in response to inflammatory cytokines such as interleukin 6 during systemic inflammatory disease. So they are not really very valuable to look at local inflammation. On the other hand, bintrexin 3 is produced at the site of inflammation after stimulation with lipopolysaccharides and pro-inflammatory cytokines such as TNF-alpha and IL-1 beta. So it is very useful to look at local inflammation. So bintrexin 3 seems to be a useful biomarker directly reflecting local inflammation, and it plays an important role locally at the site of inflammation. It can be produced by inflammatory cells such as monocyte macrophages, dendritic cells, neutrophils, endothelial cells, vascular small muscle cells, fibroblasts, and microglia. Increased levels of bintrexin 3 compared to healthy controls were detected in patients with autoimmune diseases such as systemic lupus erythematosus, ankylosing spondylitis, rheumatoid arthritis, systemic sclerosis, psoriasis, Behçet's, Takayusa arthritis, and multiple sclerosis. Therefore, we looked in the aqueous humor from patients with specific uveitic entities for bintrexin levels. And these are our findings. This is HLB27, again, very high levels compared to controls, compared to Behçet, compared to sarcoidosis and VKH. So this data shows that bintrexin 3 is another biomarker for HLA-B27 associated uveitis. I'm not going to discuss all this data, but the main conclusion of this study that analysis of the aqueous humor samples may better reflect the microenvironment of the inflammatory process and provide complementary insights. Ventrixin 3 seems to be a useful biomarker reflecting local inflammation in the intraocular microenvironment of patients with autoimmune uveitis, because also in our analysis, we showed a significant correlation between the activity of uveitis and the levels of Ventrixin 3. Our findings suggest that Ventrixin 3 might exert pathogenic role in HLA-B27-associated uveitis. However, the function of Ventrixin 3 has not been completely defined. It's a relatively new marker of inflammation, and further mechanistic studies are still needed. Thank you very much for your attention.
Thank you, Prof. ElAsrar, for the excellent talk, and I would like to congratulate you for the work that you have been done for the last 15 years. As we can see from this grand round, that the correlation between the clinical diagnosis and understanding the underlying molecular pathway of the disease is very important to establish the diagnosis, to have a correct decision and the treatment, and to monitor the disease. It is also very important in the clinical practice not to harm the patient, as Prof. ElAsrar mentioned an example of a case who was treated with rituximab, and it turned out to be Behçet disease. And we know that Behçet disease is treated with anti-TNF alpha, and if we give anti-TNF alpha to a patient with MS, it can harm the patient, so it can induce a disability. So it's a very critical. Uveitis is not an easy disease, and knowing all these details is very important in practice, not to harm or not to make more complication for the patient. So I will open the floor for the discussion if anyone has any comment or any question. Mustafa?
Thank you, Prof. ElAsrar. Interesting lecture and very nice presentation. I'd like to ask, if we can take the same guidance from this for the follow-up of the patients. For example, if the patient is Behçet or HLA-B27 and treated, and can it be for example, measured again the same cytokines or chemokines, and we find them low in case of good control? Or
in one of our papers, we did this. And we showed after 2 weeks of treatment, the levels of IP10 or network chemotherapy. Of course, they significantly decrease.
And the other question in the paper of refractory VKH that rituximab was used, what was the definition of the refractory chronic recurrent VKH?
These are patients, all of them were young females. They had very aggressive anterior segment granulomatous inflammation, as you could see. They did not respond to the maximum dose combination of CellCept and steroids.
And what was CellCept 1500 or?
We used it up to 3 grams.
Okay.
Maximum.
Okay, 1500 BID.
Yes.
Okay.
And they did not respond. And rituximab allowed us to stop steroids and to significantly decrease the levels of mycophenolate mofetil.
Okay. And sorry, one last question is the controls, taking the ACTAP. Were they pseudophakic at the time of taking the ACTAP or before the cataract surgery? When they were phakic?
These patients were no history of inflammation. They underwent routine cataract surgery. And Dr. Labidan, who was collaborating with me in these studies, he used to collect 100 microliter of aqueous humor before opening the eye.
Okay, thank you very much.
Mm-hmm.